Dr. Maitri, Dr. Maitri Chaudhary. So she'll be talking on Trust the Laser 532 nanometer Nd:YAG LPC for aggressive retinopathy of prematurity.
Good morning, everyone. Today, I'll be discussing the role of 532 nanometer Nd:YAG laser photocoagulation for aggressive retinopathy of prematurity. Retinopathy of prematurity affects the retina of only premature infants with incompletely vascularized retina. Here, the key pathology is the local retinal ischemia leading to retinal neovascularization. Spectrum of ROP disease ranges from mild cases to advanced cases with bilateral irreversible blindness. Disease progression in ROP usually follows a predictable course that is closely linked to gestational age. AROP was described in ICROP3 as a severe, rapidly progressing form of ROP located in posterior zone 1 or zone 2, characterized by rapid neovascularization and severe plus disease. There is without progression through the typical stages of ROP, and it may be associated with hemorrhages at the junction of vascular and avascular retina and iris rubeosus. This is a case of 1-month-old preterm twin which was diagnosed with aggressive ROP in the right eye. Here you can see in the zone 1, there was dilatation and tortuosity of vessels with a plus disease. And in the posterior zone 2, there is an ill-defined vascular avascular junction with intraretinal hemorrhages, dilated vascular loops, and arteriovenous shunts. You can also see in the peripheral retina, there is an avascular retina with a flat extraretinal neovascularization. So we conducted a study to find the incidence of AROP and to assess the outcome of frequency-doubled Nd:YAG laser photocoagulation in AROP in preterm infants. The study was conducted in the Retina Clinic at RIO Amritsar. The study was a prospective interventional, and it was conducted from August 23 to July 24. We included preterm infants having gestational age of less than equal to 32 weeks and/or birth weight of less than equal to 1500 grams, and those with the congenital ocular anomalies or outside these parameters were excluded. 1,000 eyes of 500 preterm infants were included, and ROP screening was done at 4 weeks postnatally with indirect ophthalmoscopy following appropriate dilatation and topical anesthesia. Disease was classified on the basis of ICROP3. After the screening, the follow-up was scheduled according to the location and the severity of the disease. And as soon as stage 3 ROP or AROP was detected, immediate intervention was needed with the frequency-doubled Nd:YAG laser within 48 hours. So the following observations were made. Out of the 52.8% of the total eye screened had ROP, out of which 7.6% of the total ROP eyes had AROP, and 4% of the total eyes had AROP, so the incidence was 4% of AROP. 120 of the total ROP eyes required treatment, out of which 100% of the stage 3 pre-plus and plus disease ROP eyes had regression with laser photocoagulation alone, and 92.5% of AROP eyes had regression with laser. But 3 AROP eyes needed an additional intervention in the form of intravitreal anti-VEGF. So the conclusion which we made from that study was that the incidence of AROP was 4% and 92.5% success rate with the frequency-doubled laser alone in AROP, and 100% resolution was seen after augmentation by anti-VEGF treatment. The clinical implications are: a routine ROP screening ensures early diagnosis. Rapid intervention in aggressive disease is essential in preventing irreversible blindness. Frequency-doubled Nd:YAG laser photocoagulation as the mainstay treatment ensures the permanent ablation of the avascular retina, lowering the risk of disease recurrence. And adjunctive anti-VEGF therapy helps achieve the disease regression alongside the laser photocoagulation in some cases. Thank you.
What was the reason why you didn't choose for anti-VEGF followed by laser in AROP? So,
So, because the gold standard basically is the laser only. If the avascular retina is visible and it can be lasered, so we should go first for the laser. Anti-VEGF is only preferred where the media clarity is not there or the disease is so much aggressive that laser won't be effective. If there is edema, the laser effect won't be there.
with recent guidelines which are coming, they say ki in AROP start with anti-VEGF followed by laser.
No,
So
sir,
do
but
you,
not every AROP case should be like we diagnose this is AROP. It should not be like first we give injection. If it is laserable, because ultimately we have to laser the avascular retina. Otherwise, even after the injection, there will be recurrence.
so do you have any double-blind study where it says ki if you give injections followed by laser, then the amount of laser which is required is less as compared to the laser if you do laser followed by anti-VEGF. So do you have any comparison or do you have
No,
any
sir, I
data
didn't
available
conduct the
in your?
study myself, but according to my experience, which I have seen, that first of all, laser also we have seen good results with the laser alone also.
No, anti-VEGF followed by laser, they say the amount of ablation required is less.
No, so only in select cases anti-VEGF followed by laser, but not every case. But study I have not done.
So I would like to say something. So we are taking care of a lot of ROP cases, and if you ask me or any international faculty, they'll say anti-VEGF is the standard of care for zone 1, zone 2 AROP. If and there are multiple studies. One of those studies is done by Dr. R.V. Azad, who has been one of the
Okay.
pioneers of ROP in India, and they clearly showed that giving an anti-VEGF injection results in better vascularization, and subsequent requirement of laser goes down significantly, like 40-50%
Yeah.
reduction in the total amount of laser that is required. In fact, we have not published it, but we are getting some data which tells us that in zone 2 AROP, about 30% of the patients might have complete vascularization without the need of any laser. So, I mean, in the age of anti-VEGF, we cannot say
If
that
it
the
is
gold standard of treatment for AROP
it will
is.
depend upon where the disease is localized also, because now ARP is not just in the posterior zone. If it is like more anteriorly,
So,
then we can.
so see, 99% AROP cases would be either in zone 1 or zone 2 posterior, maybe going to zone 2 mid. It is very rare for anybody to have a zone 3 AROP
Yeah,
or a zone 2 anterior
definitely.
AROP. So it is predominantly a posterior pole disease. Yes, there were some
Yes, sir.
cases which were anterior, so that is why now the name has been changed to
Change.
AROP. But the standard of care in today's time would be an anti-VEGF injection followed by laser. And when you're talking about the fact that when your media clarity is not allowing you to give an anti-VEGF injection, that actually is an indication for anti-VEGF
Yes.
injections, because media clarity is shown to improve once you
Improves
give
after the
anti-VEGF
anti-VEGF.
injections. The IOP goes down, the NVI is regress, the pupil dilates very well. So in today's time, to say that the gold standard treatment for AROP is laser is not probably correct.
Okay.
Yeah. Thank you, Dr. Maitri.
Thank you, sir.